Today's date is whatever, April 7th. We're going to do questions today. I do want to give you some follow-up information on yesterday, but I'm going to answer this question now as a scientist. How long do I need to wear the same surgical mask to still be safe? I have no idea. I'm not sure anybody does. A scientist will always answer a question, I don't know, they don't have any data to back it up. I have zero data to answer that question. So I encourage you guys to go find, the internet has a ton of information. And I can spend all day Googling these things just like you guys can. I'm trying to stick to the topics that are going to be a little bit more difficult to understand, that's going to take advantage of my immunology training and my physician training to answer questions. It's not my field to understand what masks are because I never wear masks on a daily basis. There's some great videos on masks and then some great stuff out there about what people in New York and other places that are short on PPE equipment are doing. And so there's a difference between what scientifically you can do with a mask, what you should do with a mask, and what you have to do with a mask. We should probably define that. But that I have no answer for that today. You guys can help me and we can have other experts up here as the chat and choose continue. These are really great, relevant questions. Do you think we'll get overflow from Kansas City, or will we get the other diseases that they can't do? I think that's a question Chris Lang can answer better than I can. And I think that's already in discussions based on how the politics and the issues within the HCA system and within Kansas City are working. As an interesting aside, I saw an article the other day of what St. Louis is doing. And St. Louis basically has developed a COVID czar. And this is a military-trained physician who's done this before with other diseases, who basically has got buy-in from every single major healthcare system in St. Louis, Barnes-Jewish, St. Luke's, all of them, to manage the resources and the flow of patients on a scale that they can redirect patients and supplies where they're needed the most. And that makes a lot of sense, because you can only control so much. No, it's really difficult from a national standpoint to say we need a COVID czar that's micromanaging us at Cass Region. But can there be a Kansas City czar? Can there be a St. Louis czar? There already is. And during these times of an emergency, you need that level of government where you have a command structure kind of like the military. And, you know, there's going to be political debate on that, and I'm not here to cause any inflammatory discussions. But there's a reason why that works well in a catastrophe in a military setting. Because when you're under fire by an enemy, you don't have time to second guess the commander. That gets you in trouble. So there's a clear chain of command, and there's a reason that exists. And you can see the analogy when I say that of what's going on here. It's having a clear chain of command is critical when we're panicking. But we need to all be trained to do your job and your job and your job, and not question authority of why we're doing it. That's Chris's job. That's Liz's job. And you guys see how this works, right? Okay. So the answer to that is yes, I think something like this is in the works, but I'm not the one to answer that question. And I think Chris can answer that question when somebody asks him about what the situation is today. So yeah, we're going to see it. In my idealistic world, I think it would be great if we consolidate all the sick COVID patients in one place and did all the non-COVID places in another. And that's exactly what New York has done. And you know, they brought those ships into the harbor. And what do they use the ships for? Well, people? Right, ideal. Because you want to consolidate people with regular health concerns away from the active infection problem. You guys know what happened to the ship? Anybody hear about that a couple days ago?
Was India hurt?
No, it's full of patients.
They turned it to COVID, didn't
They transferred 5 patients who were positive onto the ship accidentally. Yes. So that's going to happen, right? There's not a perfect scenario where we can truly isolate 100% because of the nature of testing, keeps coming back to testing, and the prodromal asymptomatic phase of this virus, and the 10% of patients who have this virus and will never be sick at all. So yet they'll be in a car wreck, or they'll have a heart attack, or they'll break their leg farming, or they'll get, their shirt stuck in an auger. So that's going to happen. And we're going to innocently take those people into a situation where we have healthy people. We can't avoid that. And there's absolutely nothing wrong with the concept. But we need to prepare to manage that. It's going to be way easier to manage it if only one or two people fit that scenario than if we're just all independently operating as a hospital system. Because even though we can direct our patients in one part of the hospital, and us healthy people are on the other part, you can see where that's going to, we're in a cruise ship essentially. And so the fewer people on this cruise ship that bring the virus on board, the less likely we're all going to get. Okay, so does that answer that question okay? Great questions. I want to spend the most of the time covering this because I think this is a very interesting question. What did you guys mean by curve? Where are we on the curve?
Yeah, is the curve better than it was, or,
Yeah.
we discussed it?
So you guys want an update on the local curve?
Yeah.
Okay.
Sure.
That's fair. And then I want to give you guys an update on what I learned yesterday about testing. For my previous discussions, those of you who are here, you guys understand that the only way to interpret the curve is through deaths and the doubling time of deaths. And you have to have 5 deaths before you even start the clock. So Cass County is not yet on the clock. I think we have 1 death, okay? When we get to 5 deaths, that's the first time we're going to measure our mortality rate. Well, it's the first time we're going to start the clock. When we get to 10 deaths, that's our first doubling rate. When we get to 20 deaths, that's our second doubling rate. Sorry, Justin. I stepped out of my blue markers. When we get to 40, that's our third doubling rate. And when we get to 80, that's our fifth. And the number of days between those markers defines the exponential curve. Let me do some examples here. The United States as a country, and the thing about that number is you can compare the world to a country, to a city, to a county, to your own home if you have enough people living in them. That you have enough that 10 people can get sick and die, but I hope that's not the situation. As long as there's enough people in your measurable community to measure 10 deaths, then you have enough to compare the world to that. I don't trust everybody's reporting because I think there are certain countries, for instance, Africa, I have no confidence. They don't mean to be doing misreporting, but they have no resources to even test or determine how somebody died. They just died because they're extremely poor. And so poor countries, you just have to assume that they're going to die and we're never going to know why. Okay? They're not immune to it because it's warm there. I do not believe that theory at all. With that said, I think for political reasons, certain countries are underreported. I do not believe China's total death. I do not believe Russia's total death. And I do not believe Iran's total death. I have no vendetta against any of those countries politically. They've never done me wrong, as far as I know. That's just my belief system. I just don't believe that that could possibly be accurate. When we have data from Italy and Spain and the United States that are showing this is clearly a bigger problem than what China reported. I do believe South Korea, I do believe Japan, and I believe Singapore. And those are the 3 in the Olympics of who's winning this curve race. Those are gold, silver, and bronze. Okay? The United States is not currently on the winner's stage. Okay. So remember about curves, exponential curves, is they always start flat. And you get confused early on until you reach 5. Everything before 5 is flat, and it matches a linear escalation. Everything after 5, you start doubling, right? And this is time. So when I drew these curves early on, and we talk about flattening the curve by social distancing, why is social distancing so important? because you apply that technique when you're still on the linear phase of the curve. And that's where you can have the biggest impact on the problem. Remember resources up here? If you're applying things when you're above your ability to save people, like ordered a new ventilator, you're saving one person. Okay? And that's probably one person over 5 to 10 days. Average ventilator time. I don't know what that currently is. Whereas you could have saved hundreds of thousands, if not millions of lives by staying 6 feet apart at this point. Do you understand why I'm focusing on this part of the curve? Okay, good. So once you get to 10, the curve will start going like this, right? And then what's happening with all these curves is they're going to go like that. And that's the curve you've seen on TV for the last 4 weeks. Okay? An ideal curve, as I mentioned earlier, is one, and its ideal is if you get right below that critical cutoff of outpacing your resources to keep somebody alive. If somebody dies because you don't have the resources, then that's a problem of surge capacity. And right now we don't have a very good surge capacity, but it's too late to fix that. We could still try to do that. GM and all those people making ventilators, I'm all about that. That doesn't mean you quit doing things up here. It means we still got to focus here. But ideally you want this to get as close to surge capacity as possible without going past that. Because if you have a curve like this, you guys know what's wrong with a curve like this? It becomes an economic problem. If we flatten the curve too much, then we're going to be dealing with this for 2 or 3 years. And we're going to be ordering our groceries online for 2 or 3 years. And we're not going to be able to see friends and family for 2 or 3 years. So when I said a couple weeks ago that you need a few idiots out there transporting it across, I said that kind of jokey, but I'm fully scientifically serious about that point. You need transmission of this virus, or else we're going to be dealing with this for a long, long time. So there's a purpose to... I want to be careful because I don't want you guys to make a mistake of letting down your guard of social distancing and washing your hands. Okay? I don't want us to get complacent because you can easily go back up here. So the question originally was, where is the United States? Our curve has been anywhere from 3 to 5 days over the last few weeks as I watch it daily. There's a great website that I can put a link to all you guys called Our World in Data, which explains everything I'm telling you about these curves in a very easy to understand format. And it shows you visuals of all these curves. And it also shows you case testing, and it explains why that's not very helpful. But the bottom line is USA has been in 3 to 5 days. And we are predicted to, and this also has predictions to dates we're going to meet surge, etc. So our curve is probably going to look like that in the United States. Fortunately, some of the people that have been making curves at the state level have Missouri and Kansas just under that curve, which is great if that data is believable. That's fantastic. I mean, literally, they've got it figured out what day we're going to have our maximum sick patients and how many ventilators we need and we have in the state. And when I looked last, we have 1 more ventilator than we actually need, which is perfect. But the question is, can we trust that? Because there's error bars on either side of that. And the error bars, of course, for all these predictions look like this, right? Have you guys ever seen the graphs where there's actually gray areas on either side of that line? That means we're not perfect with our predictions, because if people get lazy and they start going back out and playing tag football on the weekends at the park, then they totally mess up this whole concept. Okay. So the USA, I think today is at 5. Just to put it in perspective, Italy during their worst days was kind of stuck at 4. Spain was stuck at 3. Spain's the worst country by far so far. They're in last place. Italy is obviously very bad. You guys know that because you've seen the news reports. The USA was at 4 for many days, and then recently it's 5. And I think the USA is a little different because we're going to start having hot spots, and that's going to get to your question. New York was obviously our biggest hot spot. even though theoretically Seattle was the first hotspot, I think they did a pretty good job once they got annihilated with the surprise of this, of making some social changes in their city to flatten it out. And for some reason, I think California is doing better. And I don't have an answer to why California and LA is doing better than New York. They probably were seeded by the same amount of people. And if you think about it, which cities are at highest risk? They're the ones with major airports, or who had a significant amount of Chinese immigrants that went home for Chinese New Year and came back. Okay? It's very, very interesting. Why is Italy so bad? As somebody pointed out a few weeks ago, Italy's bad. Like the United States gets their migrant workers from Mexico. We have a lot of migrant workers. Guess where Italy's migrant workers come from? China. And so all those people that are residing in Italy went home to see their family and then went right back to work in northern Italy and then southern Italy. And it's all making sense now, right? We just took a bunch of marbles and went like that. And so the hot spots are going to be your major airports. Atlanta, Detroit, New York, LA, San Diego, San Francisco, Minneapolis, St. Paul, Chicago. Kansas City, thank God it has a crappy airport. And so that may be a blessing. I think it bought us some time. And Kansas City doesn't have a ton of Chinese immigrants in our society. And again, I have no politics against the country of China. This is not intended to be political at all. This is purely scientific. I just don't think we seeded ourselves as quickly as other cities. But that's beautiful because, long answer to the simple question, I'm still going. Where is Kansas City and where's Missouri and where's Cass County on this curve? Cass County hasn't started the clock, so we're still here. We're totally in control of the situation here, guys. And that's why wearing masks, you guys, we're just now buying into mask wearing. Just think if New York had been wearing masks 3 weeks ago. They missed the opportunity, but we're learning from their mistake. The CDC is telling us, not directly but indirectly, there are things you could be doing if you're still on the flat part of the curve. And that's what they're telling us. They can't force us to wear a mask because that prevents our First Amendment rights, freedom of speech and such. And there's no way, I mean, our government has to be a government. Chris still has to be a leader, so he has to respect rules and financial pressures. And the CDC can't mandate that we wear a mask. What do Americans do? They would revolt. That's what we've always done. That's why we exist. Because Great Britain was trying to control us, right? And in the 1700s, we said, screw you, let's do this on our own. We're going to do it our own way. That's what makes our country great. So, to get back on track, we're still here and we can implement plans that are going to make a huge difference in Cass County. That's why I'm here, because we can have the biggest difference locally. Kansas City, Missouri, and Kansas are all on the clock. And I don't know what total deaths, do you remember the numbers from yesterday, Liz? They're all, I know Missouri's at 5 and Kansas is at 5. So Kansas and Missouri are both at 5. Okay? And the United States is like 6 or 7, but the United States curve is going to look like this because it's taken into account all these hot spots. As New York recovers, then Chicago's going to be a mess. And if Chicago recovers, Detroit's going to be a mess. And New Orleans is going to be a mess. So the numbers are going to go like this, but they're going to continue to creep up at a slower pace because it's averaging a big, big country. But you guys can understand, what's going on in Cass County and compare that to Kansas City and compare that to Kansas and compare that to St. Louis County. And those are apples to apples comparison. So as long as our number stays better than everybody else, we're in good shape. Because we're doing our job of flattening the curve. You know, where was South Korea, Singapore, and Japan through all this? They've been about 9 to 15 throughout the whole crisis. They were incredibly successful with flattening their curve. That doesn't mean they're not having people dying, because at some point this virus is winning. It's just who's doing the best job of taking advantage of human intelligence to do the best we possibly could. So far, South Korea, Japan, and Singapore are winning this because they've taken measures here, including strict governmental social distancing and huge advantage in testing and tracing. And that means if somebody gets sick at all, they get tested, and they get tested, and they get tested, and they get tested, and they get tested. And if after they've been sick for 2 weeks, all their tests come back negative, they say, oh, they didn't have it. Sorry about all the tests. But as we're finding out, because of the false negatives, you can test when you're really sick, negative. You can test when you're still really sick, negative. You can test here, positive. Positive, 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 negative. That's how the testing really works. And South Korea in particular has the resources because they have all these companies that manufacture these tests. And they have government buy-in, and they have scientists who donated every PCR machine and every way possible to test for this. Guess where all the tests around the world are coming from now? South Korea. We're waiting on South Korea to ship us tests. Okay? That's fine. We fortunately have a good political relationship. So, this is, I think, from what I can see, an ideal number. This gets the number that's closest to what we want to be, to not go past our surge capacity, and to not have people die because we don't have enough ventilators. Okay. Meanwhile, yeah, you still need to make more ventilators. That's great. If China could ship us all their ventilators, great. You know, if we take all of New York's ventilators after they're under crisis and ship them to Kansas City, great idea. And I think we'll start seeing that, sharing resources at the national level, and at the state level, and at the city level. And then it gets back to the first question here is, will there be flow? Yeah, there should be. You know, because if Kansas City starts getting, if KU and St. Luke say, okay, we already have the sick patients, let's take them all. And guess who needs the ventilators more than we do? They do, right? And you guys probably wouldn't argue. That would be a really scary decision to make. Because invariably we're going to need the ventilator for somebody that gets in a car wreck on 49 highway. So we can't give away all our resources. And so now you get into the ethical decisions. You know, who gets to make that? It's really tough on a one-to-one basis to make that decision. It's really, really hard. And the doctors don't have the hard job here. The administrators do. My job's easy, you know. If I see somebody that needs to be on a ventilator, I just intubate them and keep them alive. That's the easiest job. The ethical job, the hard part, is the person that never sees the patient who makes a decision that's going to impact 15 to 20 of them. It's hard. Chris Lang has the hardest job in our hospital. And I don't envy that, but he's doing an awesome job. And so are the leaders at every level, like Liz and the other nurse manager leaders and leaders of your departments. I know they're doing a good job because I can see what you guys are doing. I'm not spying on you. I just make observations of your behavior. My own purpose. All right, so do I think the Midwest will get as bad as New York and California? Probably not, because we don't have as many people, and we are naturally social distanced, right? When I made one of my first videos, somebody commented, who's a farmer, I made a comment somewhere along the line that the safest job you could have in America is farming and planting row crops. Because you know how many people you're around? One, yourself. And you're in a place where if the virus is floating by, it has 1 in a gazillion chance of getting into your nasal passageway. So we are naturally spaced out better. And then look at New York City, right? This is a major problem in cities because of crowding and kids and things that we can't control. So kids aren't a problem other than they don't understand the rules. And it's not like they don't want to understand the rules. They just go give hugs to their grandparents. That's just how this virus spreads. So my point being is Kansas City's quite more spaced out than New York or LA. We have a huge advantage because of that. Plus, we have a 2-week head start. Now, if we don't take advantage of that 2-week head start, well, shame on us. And you guys in this room understand that and are doing your part. And when you go for walks at night, you know, and you wonder whether people are going to make fun of you for wearing a mask, if the CDC website technically says that's a good idea, that's your decision. And again, I'm never going to be the one pointing fingers at COVIDians, because that's not my job, and it doesn't do us any good. But what you can do is praise people doing the right thing. And when you see somebody doing a good job, just tell them that. They need to hear that. So, that's my guess. I'm not a science modeler. It's not my specialty. I'm an immunologist in the science lab, but I retired. I'm a rheumatologist who understands autoimmune diseases and immune responses to things like infections. But most importantly, I'm just passionate to take care of people around me, which includes you guys and my family. So, the final thing I want to do is update you guys on the information I got yesterday. When I said in a frenzy that I think the true false negative rate of the current testing in our state level is 30%, it raised a lot of eyebrows. And I can tell you, after speaking to viral specialists at Barnes, speaking with representatives from the Food and Drug Administration who called me on behalf of the Center for Disease Control, talking to the state lab scientists yesterday, and countless news reporters, I can tell you that I am more confident than others that's 30%. And it's all based on this one concept. The PCR sample, the PCR machines, and by the way, like I've said in every step of the way, there is no fault with an individual human being at any level here. The people at the state are running the lab exactly how they're supposed to. The scientists are interpreting it exactly how they're supposed to. The people who are running couriers are doing exactly what they're supposed to be. The county health department is doing exactly what it can and is supposed to be. And we're handling specimens the way we are supposed to be. It's just simple supply chain economics. We don't have the resources to do what we truly need to do to get accurate testing. But the bottom line is, if you take a nasal sample from a human nose, right? This is my heart for the neck. Okay? First of all, that needs to be literally in your nasopharynx, which is about where your ear is. Okay? It's not comfortable. And I was a little dramatic yesterday when I talked about it. Has anybody had a flu swab? Yeah, they're not a fun test. I had one a couple of years ago, and I would not volunteer to do that again. But it's not fun, not only for the patient, it's not fun for the person doing it. Because as healthcare workers, we don't want to harm our patients. We're obligated not to harm them. That's one of our oaths. And we are naturally going to, when we stick something in and the kids crying or whatever, we're going to not push it in as far. And the other thing is, if you go this way, you're going to get to their brain, not their nasopharynx. And most people don't realize, and when they go like this to look in your nose, you're not doing your doctor a favor. The direction of your nasopharynx is straight back, perpendicular to your head, when your chin's straight down. Okay, it's not that way. That goes to a place you don't want anything poked into. Okay? Because your brain's right there. You don't want to poke your brain. So, yeah, that's not comfortable. And again, it's no fault of the healthcare worker, but there's probably issues with how we're collecting specimens. The other issue is once it's in the tube, as I mentioned yesterday, even though there's inhibitors in there to prevent decay, there's a natural decay. And it's time dependent. And guess what? It's an exponential curve. So the further away you get from time zero, and the state lab's cutoff is 72 hours, where they say there's no point in running the test, the closer you get to that, the worse your specimen is. Again, nobody's fault of anybody's. It's just how things work. So the ideal way to do this is take it directly from somebody's nose, put it in the PCR machine. And that's how the study in China was technically done. And what they did was they took specimens from patients that were on a ventilator and had a tube going all the way down to their lungs with the highest concentration of viruses. And they considered the gold standard to be patients who at some time during their 2-week hospitalization or illness, they had a specimen that collected positive by PCR through a very sensitive testing mechanism. Okay, so they set that as their positive. Do you guys know what the rate of nasopharyngeal tests were? I mean, I know you don't know this. I'm not trying to make you play guess what I'm thinking. In the best of circumstances, whether you were super sick, mildly sick, within the first 8 days of being sick, less than 75% of those patients tested positive with the test we're currently using. It's not a fault of the testing technique. It's the fact that the combination of all these factors that we're trying our best to do shows it. So this is not truly a false negative. A false negative says there's something inherently wrong with the test. This is I don't know what the right term is. It's a false negative of the situation. And again, nobody's fault. It's what we got. We have an inherently flawed testing system that we're missing 1/4 of people who truly have this disease. And that's not even taking into account silent carriers or people who are asymptomatic. These are the sickest people. Still test negative 25% of the time, frankly at any time, but within the first 8 days is the most concerning because that's when we're sending everybody to get tested, right? And then I fudge factored. I have no scientific data to support where I got an extra 5%, but you know, give me some leeway to say that in the trunk of the car driving to Jeff City, there's not 5%. Again, I'm not pointing any fingers. Everybody's trying to do the best they can under difficult circumstances. You know, when we come up on a car wreck, we don't have a life flight and a crash cart with us. So we make do with what we got. And that's our current situation. So let's make do with what we got. The beautiful thing is I think there's really a happy ending with our testing thing. If what I think can happen locally can happen. And we'll have a talk about that later. That's enough for one day. Thank you for the questions. Nice job. And then if you guys hear people that you know coming up with things that are bothering them or questions, and you're willing to email Liz anonymously, that'll give me a list of questions, and I'll go sift through them, and I'll get good topics, I think. Because I want to answer your questions. I don't want to sit up here and lecture you about things you don't care about. Science is super boring, right? There's a reason why none of you else are scientists. Okay? It's tough. But I'm happy, and I'm happy to talk about social and economic things too. And if we need to get somebody who's better than me talking about those, then we'll get those people. So don't be inhibited by sending questions, because I think it makes us all feel more comfortable knowing everybody else has the same question. Just like in grade school, right?